Emergency medicine is more than just ordered chaos.
From the resus room to the bedside, we are witness to it all.
And we're here to help you prepare for it.
Bringing you the brightest minds in emergency medicine from around the world for trusted, tried, and true free open access medical education.
I'm Dr. Anton Hellman.
And I'm Dr. Katie Lynn.
Katie, let's welcome the listeners from our amazing EM community to the Emergency Medicine Cases podcast, shall we?
Yeah, or let's simply call it EM Cases.
Okay, EM Cases.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
This is part 2 of our update in cardiac arrest management beyond the guidelines. In part 1, we went deep into the fundamentals and the nuances behind them. We reminded ourselves that CPR and defibrillation still reign supreme, but that excellence lives in the details. Compression fraction, recoil, ventilation discipline, shock strategy, pad position, distinguishing refractory versus recurrent VF, POCUS integration, and the physiology behind every decision we make during a code. If part 1 was about mastering the mechanics of resuscitation, part 2 is about confronting the uncomfortable questions, the one the guidelines don't fully answer. Because once you've optimized CPR and shocks, what's next? Today, we're shifting to vasopressors and adjunct medications. We'll unpack what the evidence actually shows, when these meds help, when they harm, and when it might be time to stop. We'll explore vasopressin, steroids, bicarb, calcium, magnesium, whether any of them truly move the needle, and when it makes sense to actually use them. We'll talk about ketamine in cardiac arrest. Is it simply humane sedation for CPR-induced consciousness, or could it play a neuroprotective role? We'll dive into airway strategy. We'll talk about SGA versus ET tube, and how ventilation can quietly undo everything you've just accomplished with great CPR. We'll tackle termination of resuscitation, how to make that decision thoughtfully, physiologically, and ethically. We'll discuss lytics, cath lab activation, and the controversial question, should we be ordering whole body CT on everyone who isn't going directly to cath or ECMO post-arrest? And finally, we'll ask Rob and Sheldon to walk us through step by step how they ideally run their codes in a perfect world. Because beyond the algorithm lies judgment. And to help us navigate that territory, once again, I'm joined by 2 world-class experts, Dr. Sheldon Cheskas, emergency physician, resuscitation scientist, and internationally recognized authority on defibrillation and CPR quality, and Dr. Rob Simard, emergency physician, POCUS educator and researcher, and master clinician in cardiac arrest care. All right, guys, let's get into part 2. Vasopressors. We talked extensively about epinephrine in part 1. Let's talk about vasopressors and medications other than epinephrine. There's this combo of vasopressin and steroids with epinephrine. There's amiodarone, there's lidocaine, bicarb, calcium, magnesium, ketamine, and lytics, which are all considerations in cardiac arrest. So starting with vasopressin and steroids, the vasopressin and steroids combo keep resurfacing every guideline cycle. We know that there's no robust evidence that they should be used routinely in cardiac arrest based on the AHA guidelines, but I understand they may improve the rate of ROSC. So I'm not sure that, we can just forget about them completely. Rob, can you run through for us the literature to date on vasopressin and steroids and just let us know when, if ever, you would consider using them in cardiac arrest?
So we're jumping into a controversial topic to start with. But the steroid bundling, the vasopressin steroid bundle seems to have been around for as long as I've been in medicine. And it's something that the guidelines have said in the past that has shown promising evidence for, and that more research may prove that this is the way to go. But I can tell you that in all my years, it's never been something I've ever seen used in practice or know of any individual that's using this. And the literature on it isn't amazing to say that we should be stopping what we're doing and move to this. There's been some studies that showed even 25 years ago that it didn't really detect any survival or any advantage over just using, say, epinephrine or vasopressin alone. And then there's a study that showed that maybe when you bundle vasopressin, steroids, and epinephrine for in-hospital cardiac arrest, that there might be improved survival of hospital discharge compared to a placebo. But even so, like, that's not something that I've seen being used in practice, despite this coming out. In all cases, I think that when you start using steroids in cardiac arrest, you really have to have a reason for it. Although there might be some studies that show that there might be, when they run it one way, they see some statistical significance, or they run another way, they don't. I think you need to think of, what are these drugs doing and what are their outcomes that we're looking for? Now, there's certain times where I think maybe steroids would be something that I would want to use. And most of these times it's when I've already obtained ROSC. For example, if I have someone who has like known adrenal insufficiency, they might be somebody that's going to need steroids to help with their hemodynamics. Or in the COVID times, we were finding out that people that were quite hypoxic, getting a dose of steroids might be helpful as well. So there's certain circumstances where steroids could be potentially helpful. And I think it should be reserved for those types of cases where you know that there's potential proven benefit for it, or that the standard of care is to give them. But just to say routinely, hey, I've gotten ROSC, let's just give a dose of steroids to see if that's helpful. Or B, during a cardiac arrest, you're running it and you're saying, hey, you know what, let's give us a dose of steroids. Like, I don't think that that is standard practice. And I would argue in this case, more research is going to be needed, more defined to the question of whether or not steroids are in fact helpful in cardiac arrest, whether they're bundled with vasopressor and epinephrine or given on their own. And I think right now they should be used for scenarios where we've seen more of a proven benefit, or they're more acceptable that we give in those situations.
So is it fair enough to say then that post-ROSC, you're having trouble with the hemodynamics, you suspect adrenal insufficiency, maybe they're in septic shock, maybe some of those patients you might consider steroids in once you've achieved ROSC? So that's enough about vasopressin. The other thing that I'll sometimes reach for immediately post-ROSC, and I'll actually ask them to hang it for really any sick patient I see in the resuscitation room, I'll ask them to hang some norepinephrine before the patient even comes in sometimes. So we were just talking about how we might give steroids immediately after ROSC. What about norepinephrine? I mean, that seems to be kind of the standard almost go-to for as soon as you achieve ROSC and you're having any trouble with hemodynamics, then start your epinephrine. Rob, what's new when it comes to norepinephrine in cardiac arrest or post-ROSC?
I think you nailed it, Anton, when you said that it's kind of like the go-to for your hypotensive patient. I generally, when I get a ROSC back, I'll quickly assess to find out like, hey, is this hypovolemia and they need more fluid to help with this low blood pressure, and start the fluids running. But one thing that's clear for norepinephrine is norepinephrine as an infusion doesn't exist. It needs to be made. It needs to be mixed up. It's something that takes a bit of time. Even in my most acute center that I work at, my best nurses who mix up norepinephrine probably 10 times a day still take at least 5 minutes to get norepinephrine ready to run from the moment I said, let's run a norepinephrine infusion to the time it starts dripping into the patient, probably a little bit closer to 10 minutes sometimes. So you need to be ready and upfront. So I like, Anton, how you said you're reaching for that norepinephrine early and getting it ready. So if you're anticipating you're going to get a ROSC, get that norepinephrine pre-made, get it mixed, get your pump ready so that you can immediately give it when you get ROSC, so that you have it handy, and not, okay, well, we're going to give fluids and okay, they're still hypotensive after fluids. Now let's get the norepi. Well, that's got to get made, and that's another 5-10 minutes. Then you're really behind the ball. So get that norepinephrine ready, get it mixed up, get your pump ready, get it ready to go. And when you need it, when your patient's got a ROSC and they're still hypotensive despite giving some fluids, now you want to have it ready to give, and you're going to go ahead and give it, hopefully restore those hemodynamics and get that patient stabilized. I think everyone's go-to post-ROSC to give norepinephrine, other than maybe anaphylaxis, where you want to give epinephrine. Really, norepinephrine's your first vasopressor of choice, in my opinion.
So I think for me, there's lots of vasopressors, lots of choices out there. Norepinephrine may not always be the perfect one, but it's the best in a wide range of conditions. So I think levofed-tamir norepinephrine is a one of choice. The critical piece that Rob mentioned, and we see this very commonly in pre-hospital care, is you get ROSC and the time to mix a levofed drip is a period of time. So this to me is where we go off script, and I strongly suggest the use of push dose epinephrine here. So where you can actually make a small dose of epinephrine, give 10 to 20 mics, and get that mean arterial pressure up and prevent rearrest. We've seen this over and over in pre-hospital care. You get ROSC, you take too long to get a pressor on board, the patient rearrests. It's a very, very common cause of rearrest. So this is a scenario, and we see it with our patch physicians all the time, the use of push-dose epinephrine post-ROSC until you're able to get a drip up and running. And this is not automatic. As Rob said, 5 minutes in emerge, think how long it would take in the pre-hospital care field. It's a perfect area for push-dose epi for me. It's interesting, in Ontario, up until now, we've been using dopamine as our pressor. I like to refer to it as no-hopamine. Because it's actually
it's like kind of like in the past, Sheldon. Do you remember the days when we said leave a fed, leave them dead?
Yeah, exactly. And
it was incredible that there was so long where we thought leave a fed was a terrible drug.
Exactly.
Now we think
it's a
it's
drug
the
of
best,
choice. So
and now dopamine's way out.
So that's where I would come in this point, and I think the point that Rob's made too. Between the time of ROSC and mixing up a drip, that's the maximal time that you're likely going to get rearrest. You need to really quickly establish the blood pressure, and that's where I think push-dose epi has a role to play.
Is it fair enough to say then that if you have time, like you get the call in and you've got 5 minutes, ask one of your nurses to mix the norepi, and that's kind of your go-to general post-ROSC for hemodynamic support? If you don't have time and someone arrests right in front of you and you're busy with other things and you don't have norepinephrine ready, then push dose epinephrine is your go-to.
Yeah. I like push dose epi as a bridge to an infusion. That's what I like push dose epi for.
Let's move on to amiodarone and lidocaine. On our last cardiac arrest episode and on previous Journal Gem episodes, we covered the topic of amiodarone versus lidocaine, and there have been some more recent studies that confuse the picture even further. Amiodarone and lidocaine are considered equivalent for VF or pulse lift VTAC in the AHA guidelines, but there might be some important differences there. So if we go back to the ALPS RCT in 2016, that showed no statistical significant survival benefit of either drug over placebo, though subgroup analysis favored both drugs and amiodarone was associated with more temporary pacing. Then there was a reanalysis of the ALPS trial in 2022, which suggested amiodarone may improve ROSC, may improve survival and neurologic outcomes when given early, with diminished benefit as administration is delayed, likely due to adverse hemodynamic effects. Not that amiodarone doesn't work. If we give it early enough, it does have benefit. However, then to complicate things further, a large 2023 observational in-hospital registry study found that lidocaine was associated with higher ROSC, survival, and favorable neurologic outcomes, better than amiodarone, highlighting again that delaying antiarrhythmics is a key pitfall. So, Sheldon, out of this mess of amiodarone and lidocaine literature, what's your take home on amio versus lidocaine for shockable rhythms and cardiac arrest?
Yeah, so here I'm coming with a fair bit of information because I was one of the principal investigators on the Rock Alps trial, so I know where it was good, I know where the warts are, and I know what the issue is. The biggest issue in Rock Alps is we actually realized that antiarrhythmic had to be given early. So we actually attempted to give amiodarone with epinephrine together after the first shock. So we already knew that this was an issue, that drug had to be given early. As well, the formulation of amiodarone that we used was called Nexterone. It was a form of amiodarone that you could give as a bolus, and it doesn't drop the blood pressure. So there was a lot of favorable characteristics to it. But when you looked at the data, even though we tried to give amiodarone after the first shock, it was 19 minutes into the cardiac arrest. So it was late in the pre-hospital setting. I think when we look at the use of amiodarone, and lidocaine, what you have to think about very, very closely is the mode by which you're giving it. And if we look at the Rock Alps trial, if we removed the IO route in those patients, which about 20% of patients got IO, the trial would have been positive for amiodarone. Amiodarone does not get well absorbed through the intraosseous route. It should be given through the intravenous route. So I'm a big fan of RCT evidence over in-hospital registry evidence. So I'm not sure what to make of the lidocaine benefit in the in-hospital registry. But what I would say, and I think one of the biggest questions, is the guidelines right now say first dose of amiodarone after shock 3, second dose after shock 5. To me, that's way too late. I would give it as early as possible because I think all the signs suggest early is better.
So interesting. So again, just to reiterate that, so if you're going to go by the guidelines, you give amio after the third shock, but that's, like you said in those observational studies, that's like 19 minutes in, and then after the fifth shock. So you're suggesting doing it earlier because all the studies point to earlier amio is better. So we should all consider giving amio right with, and I have to admit, I've been going by the guidelines and giving it pretty darn late.
But I think that's the key. Whichever one you use, it should be given as early as possible. And there's no real good science like we go epi-amio, or epi-lido. Why do we give it ahead of time? There's no evidence that suggests why we should be giving it after the pressor. So to me, I would give it as early as possible. A good colleague of mine, Josh Lupton in Portland, is doing a trial now looking again at giving amio as early as possible. So hopefully his trial will give us some further information as to how to give it. And also just remember the route by which you're giving it. It makes a big difference with these antiarrhythmics.
Rob, you a lidocaine fan or an amio fan?
Sheldon's not the first person who I've heard now say they want to give amio ASAP. These experts know that giving the amio early is leading to at least theoretically better outcomes. So hopefully we'll have some good research to back that up, that giving it earlier will hopefully adjust the guidelines. As to now, it's still after the third shock. But let me tell you about what I learned since lidocaine's creeped back into the guidelines. So when lidocaine got back into the guidelines, if I was running a cardiac arrest and it came time for the antiarrhythmic, and I said, all right, we're going to give 100 milligrams of lidocaine, I got a whole bunch of confused looks in the room because for the past 20 plus years, amiodarone's been what's in the guidelines and amiodarone's been what's been frequently used. And the minute you start to change things, if people aren't up to date, they go, what's he talking about giving lidocaine? Like it's amiodarone. So I think that if you work in an environment where you're in like an academic center where everyone's on the same page and everyone kind of understands all the literature, you can, practice in a way where you're doing cutting edge things and saying, hey, lidocaine's back in the guidelines now as of 2018 and that it's an alternative. But if you're at a place where you're running an arrest infrequently and people are taking courses where they're learning, it's amiodarone as your antiarrhythmic of choice, and that's what they've learned for 20 years, and then you start to change it up on them, you confuse a lot of people. So keep it simple. Keep it simple. I don't want everyone starting to just say, well, this is new, and because it's new, let's use it. You're going to confuse some people in the room. The other thing too is that there's a logistics effect with lidocaine and amiodarone that people should know. And that's Amiodarone comes in a vial, 3 milliliters of 50 milligrams per milliliter. So 150 milligrams is in that vial. If you want to give 300 milligrams of amiodarone, you need to crack open 2 vials, put a syringe with a needle in, suck it out, put it into another vial, suck another 150 milligrams out, and that's your 300 milligrams that you're going to give. Where lidocaine comes in a box like epinephrine, you peel the bottom of the box apart, the 2 portions of the syringe come to the bed. You pop off the 2 yellows, you screw it together, and bam, you have your lidocaine ready to go. So from a feasibility standpoint, lidocaine is something that, comes in a box just like epinephrine, and you have 100 milligrams in that syringe. So you can give a full dose for your first time giving it and half a dose for your second time giving it to follow the guidelines in terms of the double dose for the first dose and then the half dose or however you want to divide it apart, where you give the half dose for your second dose. It's already pre-filled in a syringe, so it might be easier logistic to use, especially if you're like someone who's, maybe you do travel medicine and you have a tackle box of medications that you can bring or a school bag of medications that you can bring if you're going somewhere remote. Maybe lidocaine is what you're going to bring logistically because it's one box for your dose, as opposed to if you bring amiodarone with you, you're going to need syringes and needles and the vials with you and the laborious part of drawing them up during a cardiac arrest, where you might be the only person there. And that's a lot of, logistical things to manage during a cardiac arrest. So there's a lot of things to factor in with lidocaine and amiodarone. Other than, which one's best, there's other factors as well in terms of logistics around giving it.
All right. So Lido is not dead. It may have some logistic advantages especially for remote medicine and wilderness medicine. I want to move on now to calcium, bicarb, and mag. We know that there's no role for these drugs given routinely in cardiac arrest. I'll just say that from the top. But again, we're resuscitationists, not office docs. Rob, when would you consider giving calcium, bicarb, and mag? And for calcium, I understand that there's actually some interesting new data that suggests that even for known hyperkalemia, that calcium may actually not be beneficial. So that confuses the picture a little bit more. Let's start with calcium, and then we can talk about bicarb and mag.
Perfect. And I just want to emphasize that first thing you said. None of these are for routine use. So if you're running an arrest and you want to routinely give these medications, that is going to lead to poor outcomes. So they're not for routine use. They're for specific uses. You really need a yes or no answer, such as, will this patient benefit from calcium? Meaning, do I think they have one of the very few things that calcium may be able to reverse? So if we want to start with calcium, no role for routine use in cardiac arrest. And the usual classic things that we would consider them for, hyperkalemia, there's now some food for thought out there that maybe we don't have good proof to say that calcium in cardiac arrest where we suspect hyperkalemia is actually beneficial. And that kind of raised a lot of eyebrows. And it especially raised my eyebrows because as a clinician, I have been there where I've had somebody who missed dialysis. They come in through the front door. My nurses look at them and say, "Hey, Rob, this guy looks like crap. I'm bringing him to the resus room. We need you." And this person loses consciousness. I see this, sine wave or like wide QRS, peak T waves, ST elevation, hyperkalemia, badness, ECG on the monitor. And I say, "Get me some calcium." And, I'm giving the calcium and this ECG narrows before my eyes. And I go, okay, I've seen improvement with this. And, the patient goes on to survive, get their dialysis that they've severely need and leave hospital. And you sit there and you're like, okay, I've seen this before my eyes work in more than one circumstance. And then now there's evidence to say that in cardiac arrest that we should be rethinking that whether or not calcium's actually doing what we think it does. That classic stabilize the membrane. Is it really doing that? So it's interesting. It's definitely something to debate about. For me though, if I have somebody who's got a dialysis line in place, and is having a cardiac arrest, and I think hyperkalemia is a possibility, or a chronic kidney disease patient where I think hyperkalemia is a possibility, or better yet, I have lab results on a patient and they're hyperkalemic and they suffer a cardiac arrest, and I'm seeing like the wide QRS on the PEA that they have, and I'm seeing features suggest hyperkalemia, and the clinical pictures pointing towards hyperkalemia, they're missing dialysis, etc. I am definitely giving calcium in cardiac arrest still. I don't think that I would not do that. I think I would do that, as well as the other things I would do to help shift them, whether I'm giving bicarb to shift them or, insulin to shift them to get potassium levels down. I'm still going to do those things despite what this evidence has shown. But I am kind of now more aware that calcium has some questions about it that will hopefully have some good research between now and the next set of guidelines to better answer this question, whether the utility of calcium is what we thought it was for hyperkalemia. Other things too, calcium channel blocker overdoses, hypocalcemia are some other indications where calcium may be of utility in cardiac arrest. But outside of that, I'm not really thinking of too many other situations where I'd be reaching for calcium in cardiac arrest.
So you're still recommending giving calcium in cardiac arrest for suspected severe hyperkalemia, for hypocalcemia, and for calcium channel blocker toxicity. If you look back at the original data for calcium use in hyperkalemia, it's based on total garbage.
Exactly. You hit it right on the head.
We don't really know either way, actually, but it is hard to argue with Rob's very excellent and visual description of him literally saving a life right in front of him with the ECG changes and all. So I guess it's fair enough to say that historically we've been using this. It seems to work. And for now, we're going to continue using it. And hopefully there'll be some good studies that can show us exactly what's going on in terms of whether there's benefit or not of calcium in cardiac arrest patients with hyperkalemia. So we've talked about the calcium part. Let's move on to bicarb. Now, I've seen bicarb given a zillion times, and especially in prolonged arrests, when you have nothing else to give, it's like, okay, let's just give some bicarb. Now they're super, super acidotic. We know they are, so let's just give some bicarb. Let's do something. Rob, when should you give bicarb? When should you not give bicarb in cardiac arrest?
So once again, right at the very top, not for routine use. So that anecdote of not just do something, stand there, that's what you should do with bicarb. Just stand there, don't give it unless you have something meaningful that you're going to reverse. And if you're wondering, hey, like we've been doing this for like 10, 15 minutes, like they've got to be acidotic. So let's just give some bicarb to like reverse the acidosis. That's potentially harmful, and you can potentially be actually worsening the intracellular acidosis before you improve it. So just be very, very careful with that kind of routine use of it. That's not what it's designed for at all. What you want to do is you want to find some specifics that bicarb is going to help you reverse, and specifically sodium bicarb is going to help you reverse. So for example, any sodium channel blocker toxicities that you may have. So like TCA overdoses where you have widened QRSs on your PEA ECG in the setting where clinically someone's taken tricyclic antidepressants, then that would be a good indication to give sodium bicarb, for example. And don't forget your interlipid in that type of case as well. Your aspirin overdose patient, giving some AMSA bicarb could potentially be helpful as well. If you're a patient who has like a DK arrest where they're going to be acidotic and likely hyperkalemic, where you can give bicarb to potentially help shift that potassium as well, might be helpful. But otherwise, you're not going to find too many studies that are going to show that there's going to be improvement with ROSC or survival or neurological outcome when bicarb's given, unless it's given as like an antidote, for example, or for a specific reason, like shifting potassium, for example, as where you're going to target and reserve your bicarb for. And that's mainly how I'm using it in cardiac arrest. I am definitely not one of those people that say we've ran this arrest for X amount of time, so let's just give some bicarb. I am definitely not one of those people, and that is one of my pet peeves.
So essentially, we're just giving bicarb for ASA overdose, sodium channel blocker toxicity. So that would be like a TCA overdose or cocaine overdose. And then hyperkalemia, especially in the setting of DKA, that's when you consider it for. Otherwise, do not give it even for a prolonged arrest when you have nothing else to give and you just feel like giving something.
The only thing I would say about bicarb is that it's, for some reason, still the most commonly ordered medication by our patch physicians. It's like our patch physicians are not keeping up with science. We see it all the time. Not sure why, but we do see it a lot. I maybe keep that out or else no one will take patch anymore.
It is when you're not at the scene and you're, somewhere far away.
Exactly.
And paramedics are describing this wide, complex QRS on their PEA, and you're wondering, well, maybe is there an overdose that we're missing, and that bicarb might be helpful, or there's some DKA happening. But I think that if they're just saying, well, how long have you been running it for? Oh, well, let's just give some bicarb. That makes no sense. But if you can scientifically say there's a wide QRS, there's, a mystery as to why this person all of a sudden had a cardiac arrest, then maybe it's a shot in the dark, because the alternative is we're just going to call it. So I can see if you can rationalize it that way. But if you're just saying routinely, just give it, no, that's got to stop.
So that's bicarb, and we've talked about calcium and hyperkalemia. Let's move on to MAG. So Rob, is it kind of ditto for MAG? Don't give it routinely. Give it in very specific circumstances. I mean, I'm thinking maybe, eclampsia arrest. If they had Torsades just before they arrested, maybe an overdose that we know has prolonged QT and then they arrest. What are your thoughts on giving MAG during cardiac arrest?
Yeah, like once again, not for routine use and for very specific rhythms. So like Torsades would be a good one where MAG would be helpful. Things that prolong your QTC that you want to prevent that arrest for, like give the MAG before they arrest is more ideal. Once they arrest, you're rolling the dice. Interesting stuff about preeclampsia. So just keep in mind that if you're running a magnesium infusion during preeclampsia and your patient has a cardiac arrest while the magnesium is running, the recommendations are to stop the magnesium immediately and to try to reverse it with calcium. So if they're receiving the MAG at the time of their arrest for preeclampsia, it could be that the magnesium is causing the arrest. So stop it and then reverse it with calcium is the recommendation. Once again, very specific types of situations. So know the specific situations when you're going to give it. Outside those situations, refrain from using it in routine use.
That's a great little pearl there. We just have to remember that if you give lots of magnesium too fast, the pressure will dump. So there's definitely harms with magnesium. We got to give it slowly. My best guess is that those arrests that happen after giving magnesium are probably because they were giving too much too fast.
Exactly.
I want to talk about our favorite drug in emergency medicine. And of course, that is ketamine. And this will be a nice transition to talk about Airway. So ketamine, we've never traditionally used in cardiac arrest, but there's been lots of talk about it the last couple of years. Some patients in cardiac arrest may transiently regain consciousness during CPR, raising these ethical and practical concerns about awareness during chest compressions. We also know that ketamine has neuroprotective effects. So what do we think? Sheldon, you want to take this one? Ketamine in cardiac arrest.
Yeah, I love ketamine in cardiac arrest only because we were one of the first sites ever to report and publish on the concept of CPR-induced consciousness. So I can tell you right now, CPR-induced consciousness is, first of all, real. We see it all the time in pre-hospital care now. And the reason we see it is because it's a marker of good quality CPR. The reason people get CPR-induced consciousness is they're getting better perfusion to the brain. And in fact, we have had multiple cases in which people awake during resuscitation. They get a shock, they get a pulse, they wake up, and they're very, very difficult to handle. And most of the times they'll actually re-arrest. So it's a real conundrum for people to manage the concept of CPR-induced consciousness. I've been long a proponent of ketamine for this, mainly because of its impact on the cerebral circulation. So I think it's a good choice of drug. It doesn't tend to drop the blood pressure, although certainly the recent study of ketamine versus etomidate sometimes would question that. But I think that's a different scenario and a different research than what we're doing. Usually 0.5 to 1 milligram per kilogram IV is a dose that I generally tend to use for this, and it tends to work very, very well in the field. There's no evidence to produce, say, ketamine versus other sedatives in that particular scenario, but we've been using ketamine for this for a long period of time. So again, CPR-induced consciousness is good. If you get that in resuscitation, the likelihood of survival is much, much higher because you're actually doing a good resuscitation to be able to get CPR-induced consciousness. Once you get it, sedation is required to properly manage the rest of the arrest. And I think ketamine is the best choice that we have right now. So big proponent. I'm not a big proponent of it for neuroprotective effects. I'm not convinced of that particular portion in cardiac arrest, but for sedation and this particular condition, a big believer in it.
All right. So you're talking dissociative doses. You mentioned 0.5 to 1 milligram per kilogram. So about 50 milligrams or so, maybe 70 milligrams. What about the timing of giving it? Just like in anything in medicine, we want to prioritize, and in cardiac arrest, we definitely want to prioritize other things besides giving ketamine. Logistically, when are you going to give this? You don't want this to interfere with more important things.
No, 100%. But I do believe if you're continuously seeing during your 2-minute CPR cycles and shocking CPR-induced consciousness, you need to get it on board early or the resuscitation becomes impossible. And we've seen this again in the field. We've seen it often, and many times the paramedics will do a retro patch because they don't have time to actually patch for it in the middle of the resuscitation when they're doing other things. They'll call and say, hey, listen, I need to give ketamine for this. Or the other scenario that you'll see it in, Anton, is post-ROSC. So they get a ROSC, and then they become very difficult to manage. That's another common situation where we use ketamine in that scenario. So I think if you're doing multiple cycles of CPR, multiple shocks, you continually have this person pulling at their tube, pulling at their IVs, that's a situation to get it on early. Post-ROSC is the other situation where you're going to see it. And then again, I would try to get it on as early as possible because it's very difficult in the field or in the emergency department to manage CPR-induced consciousness without some form of sedation. So that would be my advice. Try to get it on as early as possible.
Okay, so now we're talking about 2 drugs you're recommending to get on early besides the usual epinephrine and stuff. And this is amiodarone and ketamine. And, I'm just thinking out loud now that there's so many times where you're waiting that 2 minutes. So I think you do have time to give it in there. I mean, sometimes we're just kind of waiting around. So I guess it depends on the situation, but just the general principle there would be to consider amiodarone in VFib/pulsus VTAC arrest early, even with your first epinephrine dose, and to give ketamine early. Rob, do you have any arguments against ketamine, or are you with Sheldon here?
I think Sheldon articulated very well the indications to give it. So I'm only giving it if the patient needs to be further sedated because they're interfering with either our ability to give high quality CPR or managing that airway. And post-ROSC, like there's so many priorities we need to get post-ROSC. Like now that they're talking about finding those reversible causes by essentially pan-CT scanning them or getting a good quality ultrasound. If the patient's moving around and not following commands and is inhibiting us from helping them out, then for sure they're going to need sedation on board so that we can get the things we need to be done properly and done the right way.
That segues very nicely into airway. So airway management is one of the most disruptive moments of CPR. There's bagging, supraglottic airways, and intubation. They all remain acceptable options as far as I know. When does securing an advanced airway truly help? When does it worsen outcomes? What's the latest on airway management in cardiac arrest? Sheldon, do you want to take this one?
I would suggest that the evidence strongly suggests now, certainly in pre-hospital care, in North American pre-hospital care where we don't have physicians on the truck, the supraglottic airway is the way to go. It's quick, it's easy, it secures a good airway. I would say to you that certainly some of our ventilatory data suggests that BVM, while seemingly easy, is much more difficult than most people think to do properly. And we see issues in terms of ventilation parameters when people use a BVM. I think if you're well trained and you do a lot of endotracheal tubes, that for sure would be the way I would go. But for people who don't do a lot of tubes, you got, paramedics who do 1 or 2 cardiac arrest cases a year, to maintain an efficiency in endotracheal intubation for the totality of the workforce is very challenging. So I prefer a supraglottic airway for those. In an in-hospital environment where we have physicians who do a lot of intubations, I prefer an endotracheal tube for those. So I think it just depends on who is the operator is the key piece for me.
Rob, do you use SGAs in the emergency department? When would you use a tube? When would you just bag? Any logistical tips on how to secure an advanced airway without ruining your CPR quality?
Yeah. So let's just talk about the advantage of why we'd want to advance the airway. So whether it's a supraglottic airway or an endotracheal tube, both considered advanced airways, the benefit of it is you're moving from a 30-2 to a continuous CPR procedure now. So instead of having to do 30 compressions and pause to give those 2 bag valve mask breaths in, and the reason why the recommendation is we pause is because you can't tell if the breaths are going in if someone's doing CPR. So someone has to actually take their hands off the chest while you're doing the bag valve mask to see that there's chest rise during those 2 breaths. So you're doing your 30-2. And then if you've added an advanced airway like a supraglottic or an endotracheal tube, you no longer have to stop CPR, and you can do continuous 2 minutes of CPR, and you give a breath, 1 breath every 6 seconds in an adult. Now, whether it's a supraglottic airway or an endotracheal tube, I agree with Sheldon. It all depends on your level of experience and what you have available to you. My preference in the emergency department would be an endotracheal tube. There's a lot that goes into intubating a person during CPR. Number one, the height of the bed is going to be nowhere near ideal. The position of the patient's head and neck is nowhere going to be ideal. So this is a very difficult intubation to begin with because you're not setting up the usual things you would do for your regular intubation you would do in the emergency department, because CPR is the priority and you can't really adjust the height of the bed to get it to where you would want to intubate, because the person doing CPR wants the bed infinitely lower than you want the bed. And if my paramedics have brought somebody into me and they have a supraglottic airway in, I just keep that in, assuming that I'm able to bag and I'm happy with the compliance of the bag, or that my RT or whoever's at the head of the bed doing the bagging has fed back to me that we are able to bag and there doesn't seem to be any resistance. I'll just keep that supraglottic airway in. And if we achieve ROSC, then I'll exchange it for an endotracheal tube for a more secured airway. But if they come in unintubated, I'm going to first attempt with a endotracheal tube. Now, when you're doing this, it's not like you can get them to just stop CPR for the time it takes to intubate. I do remember my very first cardiac arrest I ever went to. I remember anesthesia came into the room and it was like, stop everything, stop CPR. We need to intubate this person. And of course, the patient didn't make it, and it took them a minute of no CPR to get this endotracheal tube in. And once they got in, like, we're in now. Okay, you can resume CPR, as if CPR was like the after fact. Now we know we want almost continuous CPR from the start to the finish of the arrest. And that means that if you're going to intubate somebody, that you're not stopping CPR while you're advancing that tube. You're going to be doing it while someone's pushing on the chest, which now makes it an even harder intubation because that target is moving as they're pushing on the chest. So that would be kind of my take on what I'm doing with the airway during cardiac arrest.
Great pearls in there. So the keys are continuous CPR always with your airway. You should not be stopping CPR to get the airway. And those positioning considerations are really important as well.
And just a quick word from one of our sponsors, the Rural Ultrasound Fellowship. No matter where you practice, there are moments when decisions can't wait. Maybe imaging isn't available or the system is too busy and you still need clear answers right now. That's where a POCUS Fellowship makes all the difference and gives you the confidence at the bedside. It helps you decide that you can manage locally and when it's time to escalate care. The Rural Ultrasound Fellowship is a 1-year, fully online POCUS training program you can complete while working full-time, taught by international faculty. Learn more at ruralultrasound.com. Built for real-world decisions.
All right, I want to talk a little bit about waveform capnography, which has been this wonderful advancement over the last decade or so. It's now mandatory with advanced airways. Rob, beyond just tube conformation, which we use waveform capnography for all the time, how should clinicians use capnography dynamically during a cardiac arrest resuscitation?
Yeah, so end-tidal CO2 capnography can be a friend of yours in a cardiac arrest. So if you have it, use it. So here are some of the ways that I use it. And for listeners who might not be as familiar with it, so just keep in mind, if I'm a normal, healthy individual and I'm breathing in, breathing out, my heart's pumping normally, and you put capnography on me, you're going to get a number of around, we'll say 35 millimeters of mercury on the end-tidal waveform. You'll see a nice wave show up and you'll get around 35 millimeters of mercury. Now, say in front of your eyes, I go into a cardiac arrest. So now I'm no longer breathing and my heart's not pumping. So I'm not circulating blood and I'm not oxygenating my blood. Therefore, I'm not going to be producing carbon dioxide. So if I have a cardiac arrest right in front of you, my 35 millimeters of mercury is going to go down to 0. You're not going to detect any because I'm not breathing and my heart's not pumping. Now, say I get a lovely human being who says, we can't let anything bad happen to Rob. We're going to do high quality CPR on him. And someone starts pushing on my chest with high quality CPR and someone starts oxygenating me with a bag valve mask or an advanced airway. I am now getting oxygen into me and someone's circulating my blood by pushing on my heart. So it's not going to be as good as 35 because it's not my own system doing it, but it's going to be better than 0 and hopefully much better than 0. Our paramedics consistently get in the mid-20s with high quality CPR on their capnography. So when I'm hearing when they're doing a cardiac arrest and they're saying we're getting end-tidal CO2s of 25, I know they're doing good quality CPR and they're resuscitating that person well. If they're telling me they've had a witness cardiac arrest and they're getting end-tidals of like 8 or end-tidals less than 10, that is poor quality CPR. They can improve their better quality CPR to get that number higher, especially if they've just witnessed this person. This person hasn't been down for a long time. So you can use as a marker of CPR function. If you're getting numbers better than 10, then you know you're doing good quality CPR. Less than 10, poor quality CPR. And then say you're humming around 20, and then all of a sudden it's shot up to 45. You have a big jump in your capnography readings. That's a sign that you may have received ROSC in this patient. And if my epinephrine's due, maybe I'm holding that. Maybe I'm waiting till the next pulse check because I see this big jump in end-tidal CO2 from 25 up to 45. And then on my next pulse check, if I get a pulse back, then I've confirmed I've got ROSC. So I've held off that epinephrine where I didn't give that next dose of epinephrine because I cheated by looking at my end-tidal CO2 and it's kind of prompted me with that big spike in end-tidal CO2 that it's gone up. And then say the opposite happens. Say we've been running this arrest for a period of time and my number that was going at 25 and we're switching out our CPR people every 2 minutes and we're doing good quality CPR, but now my end-tidals are going down. They're now 10, 12, 8. And I've been running this arrest for 15, 20 minutes and I'm doing everything and my end-tidals are going down. That's a poor prognosis and a sign towards going towards termination of resuscitation. So you can use it for a bunch of things, not just confirming you're in the right spot with your endotracheal tube. You can tell your quality of CPR. You might get an early indication that there's ROSC before your next pulse check if you get a giant spike in it. And on top of that, if you've been done CPR for, say, 20 minutes and your end-tidals are less than 10, that's incredibly poor prognostic thing and something that you should be considering terminating the resuscitation. And so it gives you a lot of different parameters that you can use to help you during a cardiac arrest.
It's like a miracle tool.
It's a nice, cheap, non-invasive tool.
Yeah, that was beautifully explained. Thanks, Rob. Before we leave Airway, Sheldon, any other comments, tips, tricks, pitfalls, and pearls when it comes to Airway and cardiac arrest?
I can tell you One thing that we've seen over the years, doing this for a long time, had a number of coroner cases in which the implication was that the tube was placed esophageal by the paramedic. The number one way to get around that is a tracing of end-tidal CO2 in place. So when we see an end-tidal CO2 waveform, we know the tube was in the right place. What we do see sometimes is a loss of waveform on transfer of the patient from the truck to the bed in the ED. And if you lose that waveform, it's usually because the tube has been dislodged. So I think that's one thing to look at. If you see an end-tidal CO2 waveform in the field and you've lost it, look for tube dislodgement in those particular patients. But to us, end-tidal CO2 is the gold standard. We don't accept actually anything else.
So end-tidal CO2 is for tube placement. It's for tube dislodgement. It's for how good your CPR quality is. It's for helping determine ROSC. And it's one of the factors in deciding termination of CPR, which we'll get into in a little bit more detail later in the podcast. Rob, one of your favorite topics in the universe is POCUS. And I want to talk about transesophageal echo. In EM Quick Hit 61, we dove into TEE in cardiac arrest. And essentially, what we reviewed there was that resuscitative TEE allows continuous, high-quality cardiac imaging during CPR. It helps optimize chest compression location, so that avoids the ineffective aortic valve compression. It minimizes interruptions and identifies reversible causes like tamponade, massive PE, or hypovolemia. I mean, that all sounds pretty darn awesome. It can also provide physiologic and prognostic clues like LVOT opening during CPR, and it can guide procedures like temporary pacing or ECMO cannulation, though there's no RCTs yet that show survival benefit. We talked about how risks seem to be low in intubated patients and dead patients. Skills can be learned quickly by experienced POCUS users, but effective use requires system readiness, trained operators, and workflow integration. Rob, as a POCUS educator, what do you think the current role is for transesophageal echo in cardiac arrest? And if you do think it has a role, how do you integrate it into your cardiac arrest care?
There's a lot of things I like about transesophageal echo and cardiac arrest, but there's also a reality to it. So let's go through a few things. So it's something that a few places are doing. I can tell you not every hospital has the capability of doing transesophageal echo in cardiac arrest. In fact, here in Canada, I would say that the vast minority are doing transesophageal echo routinely in cardiac arrest. Mainly it's seen at places where you have like advanced POCUS training, where there's like fellowship programs. There's going to be that extra need to be able to be trained in transesophageal echo. So they tend to have a probe in those type of emergency departments. Really the only indication to do transesophageal echo in the emergency department right now is in cardiac arrest. So there's few and far cases, even with me, like I've only been a part of maybe 15 cases where we've used transesophageal echo in cardiac arrest. So it's not like these are like, an everyday thing where I'm using these all the time. There's a lot that I like about transesophageal echo though. You've mentioned a whole bunch of them. Gives you a really good idea of compression quality, making sure that the hands are placed in the ideal place on the chest to optimize cardiac output so that you're not really like compressing the outflow tract and you're really optimizing where you're squeezing the heart to promote the most amount of cardiac output during CPR. You get like a great view for some of the reversible cause. In fact, some of the stuff you can't even tell transthoracically very easily, like, seeing a dissection, getting a better sense about pulmonary embolism, things that are super helpful. Poor prognostic factors or reversible causes are things that can be very helpful. You mentioned about procedures. You have this incredible view. You don't have to stop CPR while doing this. You can do it while CPR is ongoing. So you don't have to waste time during your pulse check to do the ultrasound. But there is a reality to it. And let me talk to you about the reality why this isn't, adapted overnight to be the be all and end all. First, there's an extra probe, which means there's an extra cost. So there's a cost and there's got to be a benefit if you're adding costs into things. And it's not just the cost of the probe. These probes go internally into patients. So they need to be cleaned. So there's a cost of cleaning these probes, and they need to, at least at my sites and other sites, be placed in a specialized cabinet, HEPA filters. These are things that, like, your infectious disease and control people are going to want to be on top of to make sure that we're not causing any harm to patients when we're using these probes. So that's one of the barriers to access, is cost and also storage of it and cleaning of it. It is an extra skill to learn. It's not like, hey, I can do a transthoracic echo of someone's heart, so now I can easily do a transesophageal echo. Those are not like interchangeable skills. You do need to learn how to do a transesophageal echo. So there is a little bit of a learning curve to do it. And if you're going to do it, most of the time you've learned on simulators, and these transesophageal echo simulators are not inexpensive. They are $100,000 for some of them, $75,000 to $100,000 type of price range that few people have access to. So these are kind of the barriers in terms of getting an actual model on that you can practice and learn on and have an expert teach you on. So there are some other barriers as well. Also, because it's going internally, there's this concept of sinking the probe, putting the probe into the mouth, into the esophagus, which you might think would be super easy, but it's not like, a guarantee. Like, sinking the probe is a skill in itself. It's not as easy as it seems and does require some expertise to learn. And just remember, like, there are some unique complications in this case, although very rare to cause like an esophageal perforation. But if there's any esophageal anatomy abnormalities like strictures or things like that, then, you can run into complications like perforations and other things, variceal bleeding, etc., GI bleeding. So there are some complications that can occur with the transesophageal echo probe that need to be considered as well, that this isn't just a benign procedure that you're going to do. But at the end of the day, it does provide you with quick, reliable, convenient data points that if I'm running a cardiac arrest and a transesophageal echo is available to give me more data points, that's just more data for me to make good decisions for my patient. It might be a prognostic decision to make. It might make it a reversible cause that might be more challenging to find in other ways that can help me benefit my patient.
If I have a cardiac arrest right outside Sunnybrook Hospital and you're resuscitating me, I hope you have a TEE right there ready to go.
It's best if you have your cardiac arrest when we are teaching our fellows in the emergency department. So one of them can go and grab the transesophageal probe. We can get it hooked up, and then we have lots of POCUS expertise in the room. So we can run the arrest, we can transesophageal echo you, and we have all the data points to help you out. That would be the ideal time to come in and have that cardiac arrest.
Perfect. We're going to talk about termination of resuscitation now. So stopping resuscitation can sometimes be a really challenging decision to make in the emergency department. I find personally, Rob, the most widely accepted termination of resuscitation tool in cardiac arrest is the University of Toronto rule. We're a little bit biased there since we're all University of Toronto faculty. And Sheldon, I understand you were part of the team that actually created this tool. That being said, maybe we'll ask Rob, since Sheldon was involved in the original tool implementation. Can you tell us what the evidence is for this University of Toronto termination of resuscitation tool? And Rob, you're taking patch calls all the time. What do you take into account when you're trying to decide about termination of resuscitation on the phone, so in the field, and then also in the emergency department when you're actually resuscitating a patient from cardiac arrest? What's going to guide you in terms of saying we're calling the code?
Yeah. So patch phone rings. Hey, doc, I have a patient who might meet criteria for termination of resuscitation in the field. So a few things I need to know right away. I need to know, is there a basic life support crew on scene or is there advanced life support crew on scene? Because they have two different sets of criteria. So we use the termination of resuscitation criteria in this case. So usually they have a mandatory patch point before they call me. So they've usually have run the arrest for around the 15-minute mark. So by that time, they've got their defibrillations in, or they've gotten their IV access, their medications in. They've got their airway sorted out. They've got their end tidal running. So they have a lot of data points for me. In fact, usually they've even given me a brief history about the situations leading up to the arrest. So I get like a little bit of a spiel. Hey, we're at scene with a blah, blah, blah year old person. And they're giving me kind of the, found in the bathroom by family after they heard a thud, was in cardiac arrest, was instructed over the phone by 911 to do CPR. We arrived at this time. These are the rhythms that we've seen. This is what we've done. So once I have an idea of who's at scene, basic life support or advanced life support, and I hear a bit of the story, I can start to get the idea of what they've done and whether or not this is starting to fit the termination of resuscitation criteria. So if the arrest is witnessed by the paramedics, so the paramedics are at the scene, the patient's alive and talking to them, that's not something that we're really going to terminate. That's like a witnessed cardiac arrest. They should be transferring that because we're seeing them at the scene, they're alive and they're having that cardiac arrest. So the arrest is not witnessed by paramedics is one of the criteria. No bystander CPR is a very poor prognostic factor. So if someone's down and found down and there's no bystander CPR, that's another check mark towards terminating resuscitation. If there's a patient who has a cardiac arrest and receives immediate bystander CPR and high quality CPR at that, there's a better chance of survival in that case. So that might be somebody that you might want to transfer. So if the arrest was not witnessed by paramedics, there's no bystander CPR, and they're in a non-shockable rhythm, so they're in PEA or asystole, those are some of the criteria that we're using to go through whether or not someone's a termination resuscitation person or not. Also, we want to find out, was there a ROSC at any time? Even if it was brief, did you feel a pulse at any time? If they say, yes, in fact, we did feel a pulse. We had a pulse for a minute or so, and then they went back into cardiac arrest. Someone who has a ROSC is probably someone else that has a better chance of survival. So if they had a ROSC at any time, that's more towards a chance of survival. If they've not had a ROSC, then that's more towards the termination of resuscitation. And then the other thing too that we want to know, is there anything obvious that we can reverse? So if they have a reversible cause, that's an obvious reversible cause, and getting them to the hospital to give them that reversible cause would be a benefit for transfer, then they also wouldn't meet termination. So if someone comes along who is not witnessed by paramedics, has no bystander CPR, has no shocks delivered to them, is not a person who had a ROSC at any time, and has no obvious reversible cause, that is somebody that I would confidently terminate in the field, unless there was some compelling reason that I would want to transfer that patient, something in the story that they tell me, something in the paramedics experience that they want to tell me that would make me want to transfer that patient. But if they meet those 5 criteria, those are criteria that I generally use as things that make me confident that over the phone, I'm going to want to terminate. Now, I'm going to ask other questions as well, Anton. It's not just these 5 things. I'm going to ask, tell me about your end titles that you've been getting. I want to know about the situation, about this cardiac arrest. The age is important to me. If this is like a 27-year-old who's chasing after his son and collapses to the ground as a cardiac arrest, I find that very different from an 83-year-old cancer COPD patient who is receiving palliative care who has a cardiac arrest at home. Those are 2 completely different scenarios where I may do things differently in those scenarios. So there's a lot of things that play in, but those 5 things I mentioned for the termination resuscitation criteria are the things that I'm going to be asking about when I speak to my paramedics about terminating resuscitations in the field.
Okay, so just like any tool or rule in emergency medicine, it's just a basic guide, and we have to use our common sense and judgment as well. Sheldon, any comments about terminating resuscitation? There's the Toronto tool, which we just talked about. What about also in the emergency department? Sometimes I find it actually quite challenging to know when to call it. There's so many factors that come into play. Sometimes you have 4 other really sick patients at 3 a.m. and there's no one else around that you need to take care of. And you're wondering whether there's any point in going on with the resuscitation. That's just one example of the multitude of factors. Your take on decision-making when it comes to termination of resuscitation?
Yeah, so I think Rob really hit it beautifully. Like when we first designed this, there was a BLS and an ALS rule. BLS rule, unwitnessed by EMS, no shocks, no ROSC. That was 99%, over 99% positive predictive value. So when you have something that is less than 1%, which is a medical definition of futility, those are patients that we terminated. The ALS rule added to it, no bystander CPR. So that was a 4th period. And then Rob has nicely interwoven the clinical characteristics of the patient and end tidal CO2 in the argument. I just read a new article that came out from the States looking at this rule compared to the rule in Scandinavia, where they looked at it and they found when they applied it to an in-hospital cohort, the survival rate was greater than 5%. So it didn't work as well in a different cohort. Again, different rule. So many of these are going to change over time. Like the derivation of this tool was really quite a long time ago. So it doesn't surprise me that we're now finding people who apply it who may have higher rates of survival. But make sure you're comparing, when you read these papers, comparing apples to apples. Are these in hospital? Are these out of hospital? Are they North American? Are they not? Like there's a lot of those variables that people need to take into the context. But I think Rob's excellent addition of the use of end tidal CO2 to guide that in the context of the resuscitation, I think is very, very helpful. I think most experienced resuscitation scientists really try to look at that piece as well as the rhythm that the patient is in at the time. So, they can have all the rules, but there have been a narrow complex PEA with an end tidal CO2 of 30. I'm not terminating that patient in the field. So these are some things that I think experience lends a great deal to. And certainly there's for sure a certain gestalt about it. And when Rob talks about the younger patient versus the older patient, all these things come into play. So I think the rule is great. In medicine, things are never cut and dry. And I think Rob really described that well.
So in terms of termination of resuscitation, there's many factors. There's the 5 criteria of the Toronto rule, which we'll have in the show notes. There's end tidal CO2, which we've talked about. One thing we haven't talked about yet is POCUS and seeing cardiac standstill on POCUS. I have to say that sometimes I've seen colleagues terminate a resuscitation 2 seconds after they see cardiac standstill on POCUS, and I'm not sure that they're taking that many other factors into consideration. Rob, can you give us what the pitfalls are in using cardiac standstill on POCUS to help decide termination or resuscitation?
Going back to 2001, the landmark paper said, if you have a non-shockable rhythm and the patient has cardiac standstill on your bedside ultrasound, that 71 consecutive patients with a positive predictive value of 100% did not survive leaving the emergency department. So that the 100% positive predictive value of cardiac standstill with a non-shockable rhythm was something that was quite commonly quoted. There's been other studies since with very, very, very few survivors, but there has been publications of people who have had cardiac standstill and non-shockable rhythm that did have survival to hospital discharge, but we're still talking in the high 90s positive predictive value of cardiac standstill. But here's the problem, Anton. The problem is that people, when they do the ultrasound, there's variations in what people consider standstill. So cardiac standstill is not the heart's moving very poorly. Cardiac standstill is there is zero movement of the heart. Cardiac flicker, where the heart's moving a little bit, although still an incredibly poor prognostic finding, is not the same as cardiac standstill. So when people looked at images of people's hearts and they were asked, is this person in standstill or not? There was a wide variety of answers in terms of not everyone could agree on what standstill was, and that there was a interpretation bias where a heart that's poorly moving and barely moving was still described as being in standstill when that's not necessarily true. Standstill is truly no movement of the heart. But once again, don't get me wrong, cardiac flicker or a barely moving heart in a cardiac arrest is also a very poor prognostic finding. But I've seen it where I've had like PE arrests where that heart looks like it's barely moving. And then after further resuscitation, that heart's now more vigorously moving. So as I mentioned, cardiac standstill is truly no movement of the heart. That has a very high positive predictive value for death within your emergency department. And I do know lots of people that use that data point as the be-all, end-all data point. I personally use it as a data point, and it's a very strong data point. But I also want to know other things. I want to know all the other data points in a cardiac arrest before I start terminating it. But when I see standstill in a non-shockable rhythm, that's really leaning the needle towards the termination standpoint of things. I'm just getting everything, all my ducks in a row first before I'm just immediately calling the cardiac arrest. I don't immediately just say, oh, there's standstill, stop everything. I'm doing all my other things, looking at the end tidal, getting a history if there's any reversible cause, finding out if there's anything else that I can do. But in the majority of the cases, it does lead to a termination of resuscitation, and it is a very strong predictor of terminating resuscitation. Just make sure you're seeing true standstill and not calling it standstill when you're seeing just flickering or slight movements of the heart.
I want to move on to chatting about lytics and cath lab activation. I've personally used lytics intra-arrest with success more than a couple of times in the last decade, but my understanding is that there's no evidence to use lytics outside of a known STEMI just prior to arrest or a known PE by CT pulmonary angiogram causing the arrest, which to me seems just a tad too strict criteria. I mean, there's OMI, that may not be a STEMI. There's cases where everything points to a PE, but you haven't got the CT to prove it yet. Rob, what do you think the role of intra-arrest lytics are outside of known PE or STEMI causing the arrest?
Yeah, so super controversial topic. Definitely no role for routine lytic use. You do need to be reversing something that lytics can reverse. And if you are making the decision to give lytics, please do it up front. Don't run the arrest for 20 minutes and then decide, you know what, maybe we should start thinking about lytics. If you're going to give lytics, the lytic decision should be made early, and you should have strong data points pointing you towards that there's myocardial infarction or a PE. And there's some ways to help with that. So let me tell you the two obvious things. The person has just come back from the CT scanner, and the radiologist tells you that there's a large saddle PE that's causing right ventricular heart strain, and your patient has a cardiac arrest. Yes, that person has a massive PE. Go ahead and give them lytics. A person has a pre-cardiac arrest ECG that shows a STEMI. No question. If they can't get to the cath lab, you are giving them lytics. That is no question about it. But what about that person who has some risk factors? They were feeling short of breath after having a long haul flight 5 days ago, and now they're feeling short of breath and they have a cardiac arrest. And, there's no imaging, there's no nothing. You just know that they were symptomatic, and there's some data points that point towards PE. Or that person who's shoveling their driveway and is having, chest pain, goes into their house and tells their spouse they feel like there's an elephant sitting on their chest, and they collapse to the ground and having a cardiac arrest. Like, that's a pretty good story to suggest that that cardiac arrest is due to an MI. So in those cases, there's good stories with good data points leading you that way. So those would be circumstances where if I'm getting that story prior, or when I'm receiving this patient as the cardiac arrest patient, those are scenarios where I'm going to start thinking about giving lytics. Those would be the patients that I would want to consider giving it up front. So I'm then going to use other data points that can help me, whether it's an ultrasound to see if there's a regional wall motion abnormality that points me towards the fact that it's a heart attack, or if I'm seeing right ventricular heart strain with a McConnell sign and a large IVC that points me towards a PE. I will use those extra data points where there's not quite a clear history to kind of sway me one way or the other. But once I've made that decision and I say, you know what, that story and that ultrasound doesn't point me towards an MI or a PE, then I've got that lytic off my list and I'm focusing on the other things I can do. If I'm pointing towards, you know what, this is really looking like an ultrasound and that story, is plausible for a PE, I'm giving lytics at that time if I don't have anything else that's convincing me that there is another reversible cause. So I would then go ahead and give the lytics if I think that the reversible cause is a PE or an MI, and I'm giving it early. And just a reminder to our listeners, if you are giving lytics in cardiac arrest, this isn't like, okay, I'm going to give lytics, and on the next pulse check, if we don't have a pulse, we're going to terminate it. If you're giving lytics, you're really buying them. The literature will tell you an hour's worth of CPR. I do at least a minimum of 30 minutes if I'm giving lytics. After I've given the lytics, I'm doing CPR for another 30 minutes. For my PE, I'm potentially repeating the dose 15 minutes later. So I'm giving like 50 milligrams of TPA now and then 50 milligrams in 15 minutes from now. Some people give 100 up front, sure. But I'm doing CPR for at least 30 minutes. Literature will say up to an hour. So this is the case where if you have the Lucas device, this might be your best friend in this case, because that's a lot of resources if you're giving lytics and cardiac arrest. And the Lucas device can do mechanical CPR for those periods of time, and you can pause it for your pulse checks.
I'm glad we're in agreement on this one, Rob. Good. So I guess my practice isn't totally crazy that I introduced this section with. So that's about lytics. I think a similar question can be asked about cath lab activation post-ROSC. So Sheldon, which patients clearly benefit from emergent cath and which clearly do not? Because it's kind of a similar thing. It's like if they have an obvious STEMI, then they go for cath. If they don't have an obvious STEMI, I mean, I have to say I've had quite a few interesting discussions with my wonderful interventional cardiology colleagues where I'm really trying to advocate for the patient to go to the cath lab, even though they don't have an obvious STEMI on ECG. What can you tell us about who we should be advocating for cath lab activation post-ROSC?
Yeah, that's a great question because I'm with you. I think we've been doing this now for almost 15 years in terms of cath lab activation for STEMI. So there's no question there's been a huge change in the appetite of interventionalists around false positives in their area of STEMI. So they're not coming in for someone who they don't think is definitely a STEMI. And that's been a big argument, I think, in the past. Right now, in our EMS system, post-ROSC with a STEMI either before, so it was an EMS witness arrest, they had STEMI on the ECG, they went into cardiac arrest, and we got ROSC, those patients go to the lab. Patients who are usually it's a VF arrest, who we resuscitate, do a post-resuscitation ECG with STEMI, they go to the lab as well. And coma or decreased level of consciousness is not a contraindication to this. So every cath lab that we work with will take those patients. So we're seeing perhaps a little bit better appetite for STEMI mimics, so Scarboza criteria, et cetera. Our paramedics are getting really good at identifying those patients. Those patients tend to go as well. The other area is the non-STEMIs. Almost every cath lab will not take a non-STEMI now. Even as good as the story is, almost all of them will not take a non-STEMI. And the reason is I don't think there's good randomized trial evidence that they should be done emergently. And that's probably what the interventionist will take you. So it leaves sort of those air guys in the middle. So the post-ROSC cardiogenic shock, multiple pressors, recurrent VF, ongoing myocardial ischemia, those patients likely should go to the lab. I think there's 2A evidence for that. And I think those patients should go to the lab. So I think the ones we do not have strong evidence to go to the lab are the non-STEMIs, and the vast majority won't. I can tell you as well, when we call the lab for that middle group, so you've got your STEMI group, they take them. The non-STEMI group, they don't take. When you have these sort of cardiogenic shock, recurrent VF, vast majority of the lab will say go to the local emerge to have that patient stabilized first. They won't come right up to the lab because many of the labs actually don't have an intensive care physician or someone to handle the other aspects of the care outside of the PCI or the angiogram, right? So most interventional cardiologists are not trained to deal with these profoundly sick patients, and many of them will say, go to the emerge to be stabilized before you're bringing them up to the lab. So that's a perspective certainly from the pre-hospital care field. I doubt it's very different in the in-hospital care field.
Yeah, we've been talking about OMI as opposed to STEMI for like a decade now. And I mean, I'm just imagining Jesse McLaren listening to this and just wanting to scream.
Yeah, for sure. 100%. Yeah, 100%.
So, and again, it's that same argument I get into with our interventionalists that if I have something that looks clearly like an OMI, we know, not with 100% certainty, but even if it's 80% certainty, that person has an occlusion that, needs to be fixed now, especially post-arrest. Rob, your opinion on who should go to the cath lab post-ROSC besides this STEMI and cardiogenic shock?
Definitely myself, and I'm sure many of your listeners have been there where they get a pulse back, they're managing the hemodynamics, and they ask for the ECG, and they get this ECG that's showing ST depressions, that's showing T-wave inversions, and it's clearly an abnormal ECG, like something that you want to discuss with cardiology about, yes, there's no ST elevations on it, but it's clearly an ischemic looking ECG to you. And I think we've all been there when cardiology just basically says, no, not a STEMI, we're not taking. And, you know, 10, 15 years ago, this actually really, really bothered me a lot more than it does today. 10 to 15 years ago, I'd be like, what do you mean this isn't ischemia? They'll tell me it's metabolic, it's metabolic. And I'd sit there and I'd be like, you've got to be kidding me. Like he just had a cardiac arrest. Like I shocked him and we got a ROSC and he's got like this ST depression T wave inversion ECG. And I would just be like surprised that they wouldn't take it to the cath lab. And to be honest with you, in 2026, I have to say that after hearing many of the rounds over the years, I go to almost every round where a cardiologist is giving like a post-ROSC cath lab type round where they're like, should we take NSTEMIs to the cath lab? Should we do a delayed thing? Should we only be doing STEMIs? And I'm hearing their side of things. I've come around a bit, I must say. Sorry to all those emergency doctors out there that are offended by that, but I have come around a little bit more to realizing that a more selective approach during ROSC might be the right answer. I do strongly feel that any ST elevation, though, definitely goes to the cath lab. Hemodynamic instability, cardiogenic shock needs a cardiac cath lab assessment. Other than that, though, those really abnormal ECGs I've come around to a little bit, Anton. That might not be a popular opinion amongst the emergency department physician crowd, but it's how over the span of my career, I've went from being a huge advocate for like, what do you mean you're not taking this to the cath lab? This is clearly an ischemia looking ECG. And I know it's not a STEMI, but this looks terrible, to, okay, let's just see where this goes then. And let's just follow this patient to see how things go. Cardiology is going to be involved regardless because they're eventually going to go and we're going to get our critical care people involved and we'll inform them that cardiology wants to wait before taking the cath lab, and let's do the other things that we can do that are in our control. And I think even the cardiology literature might be pointing more towards that way as well, that a more selective approach post-ROSC is the way to go. We'll see. I think the jury's still out on this, though.
Soon we're going to be talking about another controversial topic, and that is doing whole body CT post-ROSC. But before we get to that, I just want to review some basics in terms of post-ROSC target vital signs. Rob, could you just review for us what your post-ROSC target vital signs are? We'll have these listed in the show notes, of course, and we won't go into too much detail about how to get there, but if you could just give us your general approach to achieving those target vitals.
Yeah, and this is where the guidelines become slightly more complicated just because there's a lot of targets that they want you to hit. But I can tell you that hitting these targets post-ROSC are like the thing to do. Like when I talked about what we can control in cardiac arrest, once we get a ROSC, hitting these targets leads to better neurological survival outcomes. So it's really our job once we get that pulse back. Yeah, like pop bottles, high fives, you got a pulse back, but now you're really going to work to hit the targets. And you got to hit these metrics because these metrics are what's going to provide the best outcome possible for your patient. So let's talk first about the airway. So if your patient isn't intubated at this time, get them intubated. And you want to really target their oxygen saturation to a really unique number, okay? 100% is really bad. So is 99%. The number to target is 90 to 98%. That's a new number. 90 to 98% on your O2 saturation monitor. Okay, so you're going to adjust your FiO2 so that you're getting between 90 to 98%. Okay, PaO2. So you're going to do your arterial gas, you're going to hit a PaO2 and you're going to keep that number between 60 and 105. That's your target to hit on your blood gas. PCO2, you want it between 35 and 40. And you want to avoid any excessive hypo or hyperventilation. You want to basically prevent any hypoventilation, prevent any hyperventilation. You know, you want to get them in that sweet zone where you're hitting these targets. Okay. Now let's talk about blood pressure. MAP is king in ROSC. So we go by MAP. You want to get your MAP above
or queen.
Absolutely. Yep. And you really want to ensure that your MAP is greater than 65. Okay, so that is what you are going to really target. And you're going to get there by fluids plus or minus pressors, depending on the clinical situation. But you really want to avoid any MAPs less than 65. You want to target also the temperature of the patient. And specifically, if you're going to remember anything, it's avoid fevers. You don't want to have any fevers. Whether you're going to target them down to 32 to 34 degrees, or whether you're going to do 36 to 37.5 degrees, whichever number you're going to want to target, just you have to prevent fevers. Fevers are detrimental in the post-ROSC patient.
Sheldon, any nuances when it comes to post-ROSC targets?
I think the big issue on the targeted temperature management side is the avoidance of fever. That, do we go to 32, 34? Do you go to 36 or not? I think the evidence, sort of the physiological evidence, is fairly strong for 32 to 34 in the sickest patients. You got someone who's really sick, they need to be cooled, and they need to be cooled quickly. Those who have a short time cardiac arrest, who don't have as much global ischemia, those patients are totally fine with the 36 to 37 and a half. But I think if you're really sick, 32 to 34, some really nice work going on with the Princess 2 trial, looking at intranasal cooling, which is vaporized, which happens very quickly, is a promising mechanism. They just published their feasibility study, the first 100 patients enrolled in Princess 2. So seeing that will be very helpful. And Tessier in France is looking at whole lung irrigation with cooled fluids to try to bring the temperature down more quickly. So, all the stuff that we had done a randomized trial looking at pushing cool fluids. And the clear, obvious issue is you just can't get the temperature down quick enough. So if you're going to drop temperature quickly, it has to be done through one of these more interesting techniques, and time will tell whether that makes a difference. So I think really sick, I think those patients really need 32 to 34.
Right. So for those really sick patients, I guess just a key general principle is to get these patients to the intensive care unit ASAP, because all these things that we're talking about are very difficult to get done properly in an emergency department. So just the basic principle of getting those patients up to the ICU as soon as possible so that they can get all these post-ROSC treatments that they need.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
One of the changes in the latest guidelines is to consider whole body CT after ROSC to identify a cause. And this, of course, is in the patients who aren't going directly to cath lab or patient who's not getting ECMO. And it seems that whole body CT after ROSC is pretty good at identifying a management changing cause, better than physician gestalt. On the other hand, whole body CT imaging kind of sounds like a fishing expedition, but cardiac arrest patients, some argue, are an exception to that criticism. Rob, let's just start with a rationale for whole body CT. So this is CT head to pelvis. What's the thinking here?
Yeah, so previous guidelines just recommended the CT head for prognostic factors. So our previous guidelines were requesting that after ROSC, when the patient was stabilized, to get them to a CT scanner to look at just their head for prognostic indications. Now, the new guidelines are saying that post-ROSC, a CT head, a CT chest, and a CT abdo-pelvis should be performed to look for anything that would have caused the cause of the cardiac arrest. Now, there is a good rationale for this because, believe it or not, these do find reversible causes. Even prior to these guidelines coming out, my ICU colleagues were doing this. I tell them, hey, I send them through the CT scanner for their head. Their head does not show a cause of their cardiac arrest. It doesn't show any microbleeds or any other of the poor prognostic features. And I see that they've put them in for a chest and an abdo CT to look for reversible causes. It might not happen immediately, but they were getting it, within the 24 hours after their ROSC to look for findings. And to be fair, like this is a patient who's getting admitted to the ICU who's had a ROSC, and there's a lot of resources and a lot of, we'll say, cost to this. So by having more data points for this type of patient, this is the type of patient you are willing to blow your budget on because they're getting so much intensive care in the ICU that you want to know as much about them as possible. So this does sound quite reasonable. And if you find out that, hey, they have a dissection, or hey, they have a PE or a mass or an intra-abdominal cause to their cardiac arrest that you can reverse and get them out of the ICU and have a better outcome, that really is value on your investment, that you're using all these resources to help in the resuscitation for the betterment of the patient. Now, not all centers are going to have this capability, especially not available 24 hours a day. So there are some limitations to when this is going to be used. Obviously, at my academic center, this is, something that's going to be done and has been going on for quite some time. It's not necessarily new. Where at other centers, this is going to be a little bit more of a push to have access to these types of things in these certain types of patients. That might be, calling in your radiologist after hours to say, we need this test in this person who is a post-cardiac arrest patient. The guidelines now suggest these tests to be done post-ROSC. That might be more for your hospital to push for those tests to be done at typical hours they might not be done, or to make them available when they typically may not be available, and to realize that we need to be a little bit more widespread in our investigations instead of more narrow.
We've covered a lot of great topics in cardiac arrest in this episode. All the ancillary meds, some airway considerations, POCUS considerations, what's new in post-arrest care. Rather than me do a big summary, I'd like to ask each of you two how you'd run a code in each of your particular areas of interest within cardiac arrest. Sheldon, let's start with you. In a perfect world with Sheldon Cheskis running the code, can you walk us through everything you would do for the patient that we presented at the top of part 1 with refractory VF?
For me, I hope these patients, we defibrillate them by a bystander AED in the field, and the patient survives and never goes into refractory VF. That's the first thing. If the patient presents to our EMS agencies in VF, I prefer that they start with pads in the AP position as opposed to the AL position. The second thing I want to do is, once we see the patient has a second shock, you need to be prepared for refractory VF to occur. And the reason for that is VF termination with just standard defibrillation is pretty good, happens about 80% of the time. The trouble is these people refibrillate 90% of the time, and most of the time that's within the first 30 seconds. So once you see VF after shock 1, be prepared for refractory VF, and don't be caught with your pants down doing the same thing over and over again. Once that happens, have a protocol in place that says, hey, I'm either going to do DSED, I'm going to do ECMO, I'm going to do stellate, but I'm going to do something differently if these patients continue to be in VF. I'm going to give my epinephrine early in non-shockable rhythms. For patients in refractory VF, I may give 1 dose early, and then I may wait 5 to 10 minutes actually before I give my second dose of epinephrine. I may give my amiodarone very early after the first shock. And then if the patient is continuing to be in VF, then I'll move to a DSED strategy. And I would do this now based on some of the new stuff coming out of Europe, likely after shock 2, as opposed to shock 3 that we see in the dose VF trial. I would manage the airway similar to the pearls Rob brought up. Pre-hospital group, mostly going to be supraglottic airways, a well-trained group, endotracheal tube, and please, this has to be done without interruptions in CPR, and I'll use my end-tidal CO2 as well as a clinical picture to really guide me through those particular patients. If a patient fails multiple shocks with DSCD, then I start thinking about the other strategies we talked about. Do we do stellate ganglion? Do we use esmolol? Do we have an institution that moves to an ECMO strategy for these types of patients? So I think that's my strategy really for refractory VF, and really preventing refractory VF is by doing earlier defibrillation, hopefully in the field. Start with AP versus AL, early antiarrhythmics and early epinephrine, and earlier DSCD than we did in the dose VF trial. That to me is the optimal management of VF.
Rob, in a perfect world with Rob Simard running a code with POCUS at the bedside, can you highlight all the POCUS moves you would make for a patient that we presented at the top of the podcast with refractory VF? Or I'll give you an A-B. You can either do the VF patient, or how about someone who comes in PEA?
PEA.
All right. This is Rob Simard, everyone, running a code in a patient with PEA in an ideal world.
So PEA is the most fascinating rhythm that you can have in a cardiac arrest, because no two PEAs are alike. And although ACLS guidelines make it seem like there's an algorithm that fits all PEAs, it really can't be further from the truth. There are no PEAs that are identical or alike. So you need to be dynamic in your management of the PEA and recognize that, you're using the guidelines, but you're also looking to get out of that 95% chance of death by improving the status quo, by using ultrasound, using your gestalt, using your clinical features to find out, why is this person in PEA? So first thing I'm going to do is we're going to have pads on the patient. We're doing high quality CPR. We're analyzing the rhythm to see what the rhythm looks like. I'm not just looking, hey, it's PEA. I'm looking, is the QRS complex narrow or wide? Is the QRS complex fast or slow or normal rates? Those are some of the things that I'm looking for as part of my PEA. Then we're back on the chest doing high quality CPR. Doing that rhythm check, I'm also taking my ultrasound out and I'm looking at the pulse to find out, is there any form of output while we're not doing CPR? Is the carotid artery or the femoral artery completely collapsing and not pulsating at me during the pulse check? Or is it uncollapsible and pulsating at me? Because that'll give me a better idea if I'm in true PEA or if I'm in pseudo PEA. Say I'm in true PEA. We're resuming high quality CPR. I'm giving my epinephrine 1 milligram IV push as soon as we can give it. And we are thinking of what are the reversible causes. If it's pseudo PEA, it all depends on the situation. If I'm in my academic center, then this is a patient where I may decide that I want to continue CPR on. This may be a person that I'm getting an art line in if I have a lot of resources, so it can tell me what my perfusion is like, how my CPR quality is, what my real-time blood pressure is at any given moment. If I'm seeing a narrow, complex QRS that's going, 90 beats per minute, and I'm seeing end titles on the screen that are showing me that I have good end titles of like 40 on the screen, and I'm seeing a pulsating pulse, I think this person's actually alive and is not in a PEA state, but is in fact in a severe shock state. And I just can't feel their pulse because they don't have a good blood pressure to allow me to feel their pulse. So I'm going to do everything I can in this severe shock state to promote my ability to feel a pulse. So that might be giving them fluid if they're like sepsis, starting some pressors as an infusion instead of an IV push. And I'm going to use my ultrasound to look for causes of shock instead of the reversible cause in a cardiac arrest that I do for true PEA. I'm doing the rush exam in pseudo PEA to look for the cause of this severe shock state. So in the pseudo PEA state, I'm looking at the heart. I'm looking at how the contractility is. I'm looking if the right ventricle is wide with a McConnell sign and a large IVC to say that I'm in a PE state and giving lytics if that's the case. I'm looking to see if there's a pericardial effusion and draining it if I'm looking at tamponade. I'm looking at the IVC to see if I have a plethoric IVC to suggest that I have obstructive shock, or whether I have a flat IVC to suggest that I have sepsis or hypovolemic or hemorrhagic shock. I'm looking at the Morrison's pouch area of the right upper quadrant to see if there's internal bleeding in the person's abdomen to suggest hemorrhagic shock. I'm looking at the aorta to suggest if this is a ruptured AAA where I have a hemorrhagic shock patient. I'm looking in the chest to see if I have a tension pneumothorax or a hemothorax or a large pleural effusion that's causing tension on the chest. I'm looking for all of those causes in my severe shock state and reversing them as I'm seeing them, as well as along the way, running pressors, running fluids. Maybe I'm doing CPR, maybe I'm not. All depends on the rhythm that I'm seeing, how the room's feeling, how quickly I can feel a pulse. Sometimes if you get that norepinephrine running or you're doing some push dose epi, you get a pulse, you can feel a pulse right away. And one key trick I use is I put my ultrasound and I center the pulse, the carotid artery or the femoral artery on the middle of my ultrasound probe. And I put my fingers directly in the middle of my ultrasound probe. So I know I'm right in the center of that pulse. And I can feel it when I do that more easily than if I just randomly put my fingers anywhere in the groin or anywhere on the neck. If I pinpoint where that artery is and I put my fingers right underneath it by using ultrasound as my guide, I'm more likely to feel it. So that's what I'm doing in my pseudo PEA. For my true PEA, I'm obviously continuing high quality CPR, giving epinephrine every 3 to 5 minutes. And I'm thinking of my reversible causes, going through the history, using my ultrasound for the reversible causes like tamponade, tension pneumothorax, PEMI. And then I'm using my clinical gestalt with the history to find out if this is hypovolemia, hypoxia, acidosis, take a temperature to make sure they're not hypothermic, thinking about whether or not this is an overdose. I'm going through all of my reversible causes to see what it is that I can get them out of this true PEA state. Asking around in the room, saying if anyone else has any other suggestions, and doing that good high quality CPR to ensure that I'm going to allow the best outcome. So that's how I'd run the PEA states, depending on whether they're true PEA or pseudo PEA.
You know, I didn't think we could top part 1, but I feel like part 2 was just as incredible. Rob, I hope that when we're working together at North York General, there's a cardiac arrest patient that comes in that we can save together. Just can't wait for that. And Sheldon, I can't wait to hang out with you at USEM or ISEM, whichever one I hope you'll be at.
Yeah.
Talk and chat more about research and stuff. Huge thanks to both of you. You were both brilliant, and I can't wait to hear the feedback I'm going to get from our listeners about what they got out of this episode.
Can I just say it was an absolute pleasure to have someone like Sheldon here who gets me excited about talking to me about, like, you know, intranasal ways to cool people, like this kind of stuff. And like when I, you know, talked about like heads up CPR, and, you know, here he is as like an expert in it, and hearing him get to chat about that, like it is so awesome. And gets me really excited to when I hear about these studies that are going on all around the world, that I can't wait to see what they're going to show to guide the next guidelines as to what the next changes are going to be.
That's great, Rob. That was so kind of you. And I think, Anton, I've been on so many podcasts in relation to cardiac arrest over my career. This had to be the most complete one I've ever been involved in. Rob, you know, whereas I give some of a research bent and some of the stuff that's going on around the world, Rob's clinical pearls are beyond comparison. And I think just listening to the knowledge on TE, POCUS, just a pleasure spending a couple hours with you guys, and hopefully our listeners really enjoy this session.
Fantastic. Thanks for listening, everyone.